Hello, come on, Kenji, and we will be learning MRI sectional anatomy. This is chapter 1, Introduction to Sectional Anatomy. I do apologize for the deep voice. Hopefully it won't distract you too much. Remember, you can always fast forward, pause, and reread sections. I am following the book, so if you get lost about anything, it is in the textbook, and always feel free to contact me. Okay, image number 1. This is a traditional axial cut. This is what we're going to learn. We're going to learn how to recognize what cut we're looking at. We're going to learn how to differentiate between anatomy and a particular slice that we're looking at. Well, this is what we call a transaxial axial cut. This is a CT image. This can be found on page 1. So, directional and regional terminology is used to help describe the relative positions of specific structures within the body. So right here we have a depiction of what the median sagittal plane, the median coronal plane, and what the axial plane looks like. For example, the knee, the top slice is a coronal slice, shows anterior and posterior. The middle slice is an axial slice, showing right and left, and the top slice is a sagittal slice, sagittal, because the bottom is your coronal cut. So the top slice is your sagittal cut, which shows your anterior, posterior. Middle is the axial cut, right and left, and the lowest one is a coronal cut, so it also shows right and left. Again, another transaxial section of the abdomen. This image can be found on page 3, just demonstrating what the liver looks like, the stomach looks like, and the spleen. It's not going to give the traditional representation of the piece of anatomy in which you're looking at. However, looking at 100 pictures, you'll begin to become comfortable with sectional anatomy. It's important to understand the external landmarks. External landmarks of the body are helpful in identifying the location of many internal structures, as well as internal landmarks. Internal structures, in particular vascular structures, can be located by referencing them to other identifiable regions or locations. This is what we call a surface rendered image of the pelvis, and this is how we traditionally like to look at anatomy. This image was obtained by converging thin axial slices, CT, thin axial slices, to have a computer generated image of what the pelvis would look like for that particular patient. This is a diagram of the anatomic regions. You need to be familiar with the anatomic regions. Look at table 1.1. This image can be found on page 5. But all of the anatomic regions, from the cephalic, thoracic, abdominal, pelvic, navel or umbilical, inguinal region, and posterior, you have the occipital region, cervical region, named for the bones in the neck. Underarm is axillary, vertebral, the back, lower back, lumbar, then sacral, gluteal region, the perineal region, which is pretty much where the anus would be, femoral, popliteal, cutaneous, and pedal is anterior, and the plantar is the soles, or the back soles of the feet. Surface landmarks of the head and neck. Need to be familiar with the head and neck landmarks. For instance, if you are looking for the TMJ, you can look at the external auditory meatus and know that the TMJ is just anterior to that. So some external landmarks can help you identify internal landmarks. And again, this is page 5. Be familiar with the body landmarks. The sternal angle is at T4, and L4 is the umbilical and also the crest of the iliac bone right there. But just be familiar with it because T4, the sternal angle, for instance, help us to identify the thoracic inlet. T10 is xiphoid tip and process, palpable, easy landmark for us to identify anatomy. Be familiar with the anatomic cavities, especially the abdominal pelvic cavity, which has no true separation, but we will discuss some of the different organs that's in the abdominal cavity and pelvic cavity. The ventral cavities are the cavity that's located on the ventral aspect of the body. The dorsal cavity pretty much is the spine and located in the posterior aspect of the body. The body consists of two main cavities, of course, just like we said, the dorsal and ventral cavities. The abdominal cavity can be subdivided into the abdominal pelvic cavities. Remember that. The structures located in each cavity are listed in table 1, period 4, 1.4. Sagittal view of the body cavity. So well, this is actually a coronal view of the body cavities. The picture that we looked at was a sagittal view. I'm actually reading in the book right now. So this would be more or less a coronal image, frontal image of the body cavities. And again, be familiar with the different organs that fit inside of the cavity: thoracic cavity that house the heart, lung, trachea; the abdominal pelvic cavity, of course, the liver, pancreas, small intestine, ascending colon, stomach, spleen, the different organs, the appendix, and the pelvic cavity. The abdomen is bordered superiorly by the diaphragm and inferiorly by the superior pelvic aperture, or the pelvic inlet. It's just an imaginary opening that symbolizes the beginning of where the pelvis begins, the beginning of the pelvis. Okay, this is a diagram of the non-abdominal regions. The right hypochondrium, epigastrium, left hypochondrium, the right lateral, the umbilical, left lateral, the left inguinal and right inguinal and hypogastrium. Some people say the right and left lumbar region instead of the right lateral region. As long as you understand that there are 9 abdominal regions, so the abdomen can be further divided by 4 planes into 9 regions. The 2 horizontal planes are the transpyloric and the transtubercular planes. The 2 sagittal planes are the midclavicular lines. This is a diagram of an anatomy that is projected as a pixel, which is 2D, or voxel, which is 3D. Remember, pixels are 2D, voxels are 3D, and is on a digital screen. So each digital image can be divided into individual regions called pixels or voxels that are then assigned a numerical value corresponding to a specific tissue property of the structure being imaged. So pretty much the computer is digital and need information to be presented to it digitally in order for it to understand. So that's where pixels and voxels come into play, because the computer will rather have numbers, so therefore it is divided up into a group of numbers, and then it is converted back to an analog format from a digital format, pretty much what we see here, so that we can appreciate it, because we love an analog format, whereas computers like the digital format. This is page 8 under image display. So grade level enhances or settles out anatomy. Important to understand, the grade level is to enhance the anatomy of interest. So whenever you're manipulating the grayscale of your image, MRI or CT, you want to make apparent the anatomy of interest. In this case, we're taking a picture of the thoracic cavity, so we have heart and lungs. So it depends on whether you're looking at the lungs or whether you're looking at the heart, whether the appropriate grayscale would be. The window width is a parameter that allows for the adjustment of the grayscale number of shades of gray, and the window level basically sets the density of the image. Basically what we're looking at is a CT, and window width and window level are both CT terms. However, you can manipulate the grayscale in MRI. Okay, this is different sequences that you will be using in MRI will enhance different tissues. You have to know the anatomy that you're looking at, and you also have to be aware of the pathology that you're looking for. That will indicate which sequence that you use. Down on this slide, you have a T1 weighted image, a T2 weighted image, and a proton density. Generally, they say the T1 weighted image to look at anatomy and the T2 weighted image is to look at pathology. So in the T1 weighted image, you see the CSF is coming up black, whereas in the T2 weighted image, the CSF is coming up or being depicted as white, bright. So the grayscale in MRI image can vary greatly because of inherent tissue properties and can appear different with each patient and across a series of images. So you must be familiar with that. This is a picture of the brain. They have figure 112 digital cube. This is how the computer looks at the image in which you look at. Like I said, the picture likes digital information, so therefore the computer likes to deal with numbers, and then it has to be transformed back so that you can understand it in an analog format. So post-processing technique depends on creating a digital data stack from the original 2D images, thereby generating a cube of digital information. So you have an analog image that you're taking a picture of. Once you take the picture, the computer through the Fourier transform it into a digital cube stack of numbers, and then it is an inverse Fourier transform is applied to it, where it's depicted back to you in an analog format anatomy that you can readily identify. And remember, it's a stack of slices that are combined to demonstrate anatomy. So the stacks can be combined to demonstrate a volume, or like a volume set, like a cube of anatomy. And computer enhancements can identify the anatomy of interest. And for the different planes that we were discussing earlier, the sagittal, axial, and coronal, how we depict it, this is how the computer sees it. The computer will take a cube, a digital cube of information, and if you wanted it in a sagittal slice, well, it would cut it this way. If you wanted it in an axial slice, well, it would cut that digital information in this fashion. And if you want a coronal image, it would manipulate the cube, the digital cube, in this way. And this is how the computer recons the images. We call it multiplanar reconstruction. It's an MPR for short. So if you ever run across MPR, remember it stands for multiplanar reconstruction. And this is here we go. This is the MPR tab. So once you have that digital cube, you can manipulate the information however you see fit to see the anatomy of interest that you are specifically looking at. You can even look at it in a curved planar reformation. This would come into this would come in handy when you're looking at curved structures such as the mandible of the jaw. If you wanted to look at all the teeth in one slice, one particular image, you can have a curved mode. If you wanted to look at scoliosis of the spine, sometimes it might be difficult to look at a compression fraction when a patient has severe scoliosis, a twisting and bending of the spine. Well, you can use the curved planar reformation to elongate or straighten out the spine, therefore making a crushed vertebral disc more apparent to you. Maximum intensity projection, that's what this image is depicting. So pretty much what this image is saying is that as a ray goes through an anatomic body part, as you make that digital cube of information from a volume of anatomy taken from a patient, okay, so you have a digital cube of information. A ray is looking at all of the pixels or voxels on one particular level of the cube. Well, what a maximum intensity projection is on that one particular stack of voxels in that digital cube is going to display the voxel with the greatest intensity. All the other voxels on that specific ray will not be depicted on the screen. So a maximum intensity projection only uses approximately 10% of the information because the rest of it is disregarded. This comes into handy when you have enhanced body structures and you want to see the body structure more clear, or you want to separate the enhanced tissue from the unenhanced tissue. You add contrast to that tissue, and that contrast is what's picked up during that ray when you try to segment out the maximum intense voxel. So that's all maximum intensity projection is. You're looking down a ray and you're going to depict the brightest pixel, and the rest of the pixels you're going to disregard. That is introduction to sectional anatomy.